Okay, so this is a recording on the Wednesday evening session. It's about 8 o'clock, and we'll just make a start. And if someone joins us a little later, we'll definitely bring them up to speed. What I should be sharing, or what you should be seeing at the moment, is the handout. We use these handouts. That was one of the things that I introduced, and I kind of asked whether that's working, whether that's not working, and you absolutely don't have to use them if you don't feel that they're useful to you, but they are designed to provide kind of a review of the key concepts, key anatomical structures, and key physiological processes in a class. So since we didn't get a chance to finish that off and review that on our face-to-face class, I'm just providing it here now as sharing the answers as a recording and as a live online session. But we will take time during our next face-to-face class to go through it as well. And like I said, this style of learning using review sheets might not be for everyone, so you use whatever works for you. Typically how I've designed these is that if there's something missing, these gaps, they are keywords, they're key concepts that I really want you to take away from the chapter. So it's trying to do a little bit of that reinforcing by writing it out. Other thing that you'll see that I do quite a bit is using color coding. I myself am very visual learner, but it doesn't mean that you have to be. But in case that should help you, it is there. So kind of matching names of structures with the structures that you see on the diagrams. And I'm not going to go through answers to all of these. Since this is a recording, you have a chance to pause and then continue as you are filling the answers to your study sheets. And like I said, I'm not expecting you to have gotten any further than going through the anatomy part of the chapter, because that's where we got on our last live online session. So approximately through the first side of this two-sided document. As we are getting started, I'm also going to share a little bit while that screen is there with the correct answers. I'm going to share with you a little bit about the few changes that I've decided or I've included for these Wednesday sessions that we have remotely. So for a while, I've been kind of wondering, when we first moved to a fully online setting with the pandemic raging around the world, we simply took a lot of the teaching that would take place in a classroom and offered the same classes, same sessions in a live online setting. So that's how these Wednesday sessions came about. You will notice that I offer also to you a recording that goes into more detail of each chapter and in form of a multiple chapter lecture videos that are available to you also on your learning management system Canvas. So now that we are meeting face-to-face again, I have been kind of going back and forth what would be the best use of including these Wednesday sessions when we meet virtually. And one of the things that I've come up with is that rather than revising the material again, since you're getting the lecture material as lecture videos, as a class, kind of a class teaching sessions, it feels a little maybe redundant to offer them on Wednesdays again as a summary. So what we're going to do, we're going to go through the learning material and the chapter material, but how we're going to go through it is going to be a little bit different. So I'm trying to include a little bit more of a clinical perspective. So we'll go through it kind of focusing on a lot of medical imaging, dissection pictures, So really getting to the actual stuff through case example, through examples. So it's probably going to be most ideally designed for once you have the basic grasp of the chapter concept as kind of a review of it in a little more condensed manner, but in a way that challenges you hopefully a little bit as well in terms of the clinical application of the material. So that's the plan and that's the design for this session. And I think that at this point, especially if you have paused and then continued, paused and continued, you should have had a chance to work through this review sheet that's being shared on the screen. And of course, like I said, we will take the time to go through that also in our face-to-face class. So I'm going to jump out of this document. And what I'm going to share instead is going to be a PowerPoint. And this is the more of a clinically oriented PowerPoint, as I mentioned. And while I'm getting it all set up, I'm simply just positioning a couple of windows in case we have others joining us remotely so that I don't miss anything. I don't miss anything on the chat and so on. So I'm just getting everything into place if you're wondering what I'm clicking around there for. So like I said, this is going to be the evening session for this week, week 9, where we looked at the respiratory system. And it's going to be a revision of the key anatomical concepts. And I know we didn't get to the physiology yet, but we will get to that in our face-to-face class. So you can use this recording also as a review of the physiology as well. And as we are getting started, I do believe in kind of utilizing the questions that I get from my students, because I have been really lucky that I've been teaching for quite a while. And a lot of my students from this institution, from other institutions where I worked, are already dipping their toes into medical field. So they're working on various roles in a medical field. They might not be exactly yet where they want to be in terms of their career, but they're getting there. And as part of that getting there, they come up with very good questions, and questions that I myself wouldn't always think of. I wouldn't realize them. So I try to include a lot of the questions that I've been presented if I don't get new questions, so we can cover the chapter by using that angle on that. And one of the questions that I was presented some time ago was from a student who worked as a carer and was caring for elderly patients. And we were talking about the effects of smoking, which ties in really nicely on our chapter of the respiratory system. And since we know that smoking is not ideal, how to, as a carer, apply that knowledge when working with elderly patients, and how bad is it? And what can you do? So let's start with that, just kind of to get us thinking of the subject matter. So we do know, it is widely acknowledged that smoking is unhealthy. It is an activity that plays role in many seniors' lives. And I guess that we should start by looking at why smoking is so detrimental to health. Well, the lungs are not designed to cope with the smoke instead of air. So the cigarette smoke contains many toxins, and these toxins are really an issue for us that we need to address. It is worthwhile to note that smoking is a habit that's bad for the health of both seniors, but also everyone else around them in this setting that my student was coming from. So as a caregiver, she was being exposed to secondhand smoke, which also includes significant issues for her health. What I have here is a picture of a healthy pair of lungs. We can see the heart there as well, and smoker's lungs. And you often see these pictures and you just think of that, oh, are we just trying to frighten someone? I'm going to share a very short personal story. So I am a former smoker. I smoked in my youth. When I conducted my first proper postmortem for a smoker, seeing the lungs and the damage that was just visually obvious to the smoker's lungs really was the wake-up call for me. I think I, of course, not with the patient there, not with the catheter there, but I left. I threw up a couple of times and I returned back and never smoked again. So these are not just over-exaggerated pictures to make you freaked out. It is real. The changes to the lungs are real and something to be considered. I just wanted to put it out there that I'm not trying to scare anyone. There is a real rationale and real reason why we need to pay attention to this. The other thing that I wanted to talk a little bit about is to consider some of the reasons why it makes it especially hard on the elderly people to quit smoking. So smoking can we can approach this smoking issue from many perspectives, and one is to consider also the psychological aspects of everything that's going on. So it might be a nostalgic reminder of the things, activities that have been conducted when they were younger, or a way to cope with being unable to control all aspects of their life. So as we age, as we become dependent on medical care that's provided to us by others, we do lose some of that self-control. So that might be one aspect playing to that we're trying to hold on to the things, activities that we can do, that we have a control over. And of course, we do need to bear in mind that smoking is also an addiction that is hard to kick. I often think of things, addictions that we have available. Would we, if someone came with cigarettes or came up with alcohol these days for the first time, would we even allow those to be made available as a recreational activities? And I seriously doubt that. I would go even as far as questioning, I wonder if sugar was invented today, would that be allowed to be released to the public as a recreational activity? The other thing to consider when we're talking about stopping smoking is that the stopping is especially hard because a sudden absence of nicotine, since we are used to a certain level of nicotine, if that suddenly drops, that can cause in the immediate time term elevated heart rate and also elevated blood pressure and also nervous issues. So we will see physiological symptoms, almost like withdrawal symptoms in that case. So it's something to bear in mind. And getting through those is really something to keep on mind. Also, we need to keep on mind that we are aware those changes happen and where the patient that we're caring for is at that time. So we're not risking their health. Of course, stopping smoking is great, but do we need to do it in a controlled manner? Do we need to have medical supervision available? In terms of if we think of the effects on seniors, so seniors in particular are prone to negative health issues that arise from the inhalation of the smoke. And this is due to two things: their advanced age and their reduced ability to heal and also resist diseases. So seniors are especially vulnerable for the negative effects of smoking. So I guess that brings us to consider how to stop smoking. And quitting a habit is difficult for anyone, and for seniors who may have smoked for decades, it might be especially challenging. I do like to point out that some medication-based aids for quitting smoking are not appropriate for seniors due to some of their health conditions. I'm not saying all seniors are alike, but as a population, we might need to be more careful there. In general, not just with seniors, but in general, one of the best ways to quit any addiction is to replace it with a healthier habit. So, for example, replacing smoking with chewing gum, that would, for example, satisfy the craving to have something in the mouth. One example of this is that often what I see with smokers is that especially after dinner, there's that craving to have a cigarette after a good meal. Digestion starts at the level of the mouth, as we will discuss later on this course. So really, it might be kind of part of that pathway of stimulating digestion, so that we're seeking for gratification for that. So doing the chewing gum kind of replaces that craving, at least to a certain extent, and it also might help with taking the mind off from that nicotine and craving for it. Alternatively, a piece of sugar-free candy, other favorite treat, might work well as well. Again, we're getting busy. A lot of time there is that little hand activity with cigarette addiction, that if we can replace that with something else, that might help. In terms of the caregivers, since this a student of mine who asked about this was working as a caregiver, I do want to empower you a little bit. So caregivers are optimally placed to help some of their elderly patients to give up the smoking habit. They are able to keep an eye on their customers, remind the customers why they are quitting in the first place. So kind of work as a sound of conscience, if you wish, the good angel sitting on the shoulder, reminding that why are you doing this? And often caregivers are trained to be tough when needed, while still maintaining this caring and compassionate demeanor. So I would say that a lot of carers would make perfect addiction counselors. So do not hesitate to use your expertise. You know your patients, you know your customers well, you know that balance between the tough love and being the caring, compassionate. As for the potency of the cigarettes, I also wanted to say that, of course, the unfiltered cigarettes have the highest potency. They are the most problematic. So I would really try to steer away from those, or at least move gradually away from those. The other thing to keep in mind is that manufactured cigarettes have advertised nicotine and tar rating. So they use chemicals in the production process to lower the nicotine and tar in the tobacco. That's to the advertised levels. What's probably quite mind-blowing or worth considering is that those chemicals still do remain there, even though we lower them. And another thing that I often talk with my students is that what nicotine and tar is removed is often as a part of the production process. That is often, or at least in the past, that was the case, sold as a pesticide. So we are really removing something very toxic, packaging it, selling it for the other use. So that alone, to me personally, is a warning sign that should we be consuming that? Well, that was kind of to get us started, get us thinking of the respiratory system. But what I really want to do next, I do want to share a very beautiful dissected specimen with you. And as we are starting to work our way through the respiratory system anatomy, I also want to kind of take us to consider a couple of key points. So let's start with considering what is the structure through which most air enters to the respiratory system. And of course, that structure is gonna be our nose. So what we find, nasal cavity has three important functions, and we're starting to meet those functions already very early on this respiratory tract. The most anteriorly, we have hairs at the nostrils typically, and the role of those hair is really to filter off any large particles from the air that enters to the respiratory system. Another thing that I do want to share at this point is that sometimes we might recruit the mouth to get more air into the respiratory system. And usually if we end up recruiting the mouth, that serves purposes of either increasing the volume or the speed at which we're getting the air to enter to the respiratory system. However, what we notice when we recruit the mouth, we are losing some of the benefits that the respiratory system's first part, the nasal cavity, does, some of the key functions that we have assigned for it, for the air. So we might have some of the lose out on that and have some of the signs and symptoms that we see. So, looking at this beautiful mid-sagittal cavitaric dissection, and then we have also, we're going to work through some of the key parts. And what we also have, we have on the right-hand side of the screen, a couple of endoscopic images. So what we're looking here, we've got a camera within the nasal cavity, and we're starting to see some of the important structures that we'll talk about. On the first picture, what we're seeing a really swollen turbinate. So that's much larger than it should be. And also the color of this endoscopic image is giving me a little bit of a concern. It is very pale mucosa that we see here. This second picture is much more aligns with what I would expect to see. So the turbinate don't seem to be swollen. They seem to be of the size that I would expect them to be. The color of the mucosa is more normal looking, and so on. So that brings us to have a look of the first part. And first part that I want to discuss is going to be our mucosa that lines the nasal cavity. So this whole area of nasal cavity that we're seeing here is covered with nasal mucosa. You remember the goblet cells that we spoke about in the class, and how the goblet cells served a purpose of secreting secreting mucus. And this mucus really is important to meet two probably of the important roles that we have assigned for the nasal cavity as a part of the respiratory system. So let's have a look of those functions that what we're hoping to achieve with the nasal cavity air passing through there. So the first of all, I want to discuss about how we want the air that enters further into the respiratory tract to get humidified as it passes through the nasal cavity. So we're adding humidity to that air. And a good example of why that's important is if you have ever gone out on a cold winter day when the air is really dry and taken a deep breath through your mouth. That air now wouldn't have gotten a chance to get humidified in our nasal cavity, and most of us probably would end up coughing with that cold, with the dry air hitting the lungs that we're not expecting and are not adjusted for dry air. So we try to humidify the air before it enters to the lungs. The second row, I kind of already alluded to that. The air outside typically is not quite as warm as our internal body temperature. So bunch of cold air entering into our body could also be problematic, cause us to cough as the cold air hits the lower parts of the respiratory tract. So kind of to meet that need, that we don't get the shock of cold air rushing to the lungs, we start heating up the air within the nasal cavity as well. And the third function, we've already seen some ways of dealing with it, but we have additional ways, has to do with filtering the air. And filtering the air that's gonna be entering to the lungs. So obviously we do not want particles that don't belong to the air to enter to the lungs. We don't want any pathogens, not also non-living elements that shouldn't be into the lungs. It's quite a bit of work to clear substances that have gotten to the lungs that shouldn't be there. So for that reason, we want to filter as much of the air as we can. And we saw that started with the hair at the nostril, but also continues at the other parts of the nasal cavity. And if we look at how are we able to accomplish all of these things with the nasal cavity, it all comes back to these goblet cells producing this mucus membrane of the nasal cavity. So what we notice, the nasal mucosa, it's much thinner than the skin, so that's why we get heavier nosebleeds, heavier bleeds than we would get by touching our skin. There's a rich blood vessel supply right underneath this thin layer, so that's how we're able to bring in a lot of heat to this side. The blood carries the heat from the core of the body to the surface of the nasal mucosa, and from there we're hoping as much of the air as possible to get in touch with that warm surface and heat up. Similarly, the goblet cells that produce this sticky, wet mucus, we are hoping that the air gets humidified as it's in contact with that. Finally, the mucus, like I mentioned, the mucous membrane is sticky, so any fine particles that didn't get filtered out at the hair of the nostril, we're hoping that again they get stuck on that mucous membrane, and then we can sneeze them out or get rid of them within the nasal cavity in other ways. If you think about it, it also includes the mucous membranes that are coated, the mucus-coated membranes include great amounts of immunoglobulin A. So that's going with them when we talked about the defense systems, immunological defense systems. So kind of ties into that as well. What I'm going to do next, I'm just going to erase the highlighting that I put to the nasal cavity because I want us to pay attention there a little bit more to some of the structures that we can see. And some of these structures that I want to discuss are these protrusions from the nasal wall, from the lateral wall. And we kind of mentioned them as turbinates earlier on, but what we're going to do, we're going to call them conchi. And these conchi serve two different purposes. You'll notice they come out from the lateral walls of the nasal cavity, kind of as these bumps. And what we learned when we talked about the cell surface and cell surface area is that one way to get more surface area was to produce protrusions from the normal wall. So what we're doing with conchi, we're increasing the surface area of the mucous membrane there within the nasal cavity. So with the increased surface area, we have more chances for more air passing through this structure to get humidified get heated, and get filtered. Another thing that conchi does, in addition to increased surface area, is that conchi also, in terms of their shape, plays significant role in how the air flows through the nasal cavity. They form this kind of a turbinate, get the air to turbinate, rotate as much there. So again, we're getting as much of the air mass in close contact with this mucous membrane that lines the nasal cavity. Again, in order to humidify, heat, and filter the air. Another structure that I want to point out from this diagram, just simply because we didn't really get to talk about it a lot, I mentioned it, but I never showed a good example, is here at the back of the nasal cavity. What we can see here is an opening of the auditory tube. So this tube connects to our inner ear. And you remember that our inner ear and external ear were separated by the tympanic membrane. And sometimes with the changes in the air pressure, when you climb higher elevation or when you drive through a tunnel, you can feel like your ear is getting blocked. And at that time, we often tell you to swallow, for example. The role of swallowing is that we try to get some of the air through that opening of the auditory tube to the inner ear, so we get that balance of air pressures the same on the both sides of the tympanic membrane. There are a few other names that you might see being used, as an Eustachian tube or pharyngotympanic tube. This is also the role why when you're flying, you're being told that, oh, chewing gum when you're changing the altitude, plane is changing the altitude to avoid the ear from getting blocked. What else can we see on this picture that would be worthwhile to highlight? It is a really good picture. It contains a lot of structures that we've seen. We can see anteriorly the hard palate, so the bony structure within the roof of the mouth, floor of the nasal cavity. And more posteriorly, we are able to then see the soft palate and uvula at the very end of it, the hanging bit there. We also can see, and we haven't really talked about it, but I do want to point out, since it's showing up really nicely here, is the tongue muscle mass there, much larger than what we easily see when we look into someone's mouth from anteriorly. Really very prominent structure there. As we look further down the respiratory tree, behind the nasal cavity, behind the oral cavity, and before we get larynx, we're seeing an important structure, which is, of course, gonna be our pharynx. So let's study pharynx in a little bit more detail. Pharynx can be divided into three parts based on the structures that immediately precede them. So behind the nasal cavity, we have the nasopharynx. Behind the oral cavity, we have the oropharynx. And then right before we get to the larynx, we have our laryngopharynx. So those should be familiar from our discussion earlier on in the class. and worthwhile structures that we can really nicely see on this mid-sagittal cavitaric dissection. Larynx, then we'll talk about larynx a little bit more, the voice box, in a couple of future views that we will see. What I wanted to show next is a coronal section of a dissected specimen. And we can see a lot going on here. So let's, rather than scribbling over this, I just want to show them with a pointer so I don't block the view from future structures. So one of the structures that we see here is the nasal septum here. So that's the midline separating the two sides, two halves of the nasal cavity. I'm going to change my mind and I will draw it here. So that was our nasal septum. On this particular individual, it is very straight. That is not always the case. Nasal septum is not always that straight. So don't be surprised if on a patient you see it being less symmetrical. But that does in general form the midline that separates the two sides of the nasal cavity. Another structure that's showing up really nicely on this particular diagram are the nasal conchi that we're seeing. And actually, even though on this image, we're only seeing the middle and inferior nasal conchi, we do have three of them. So we have superior, middle, and inferior nasal conchi. So I want to just mention those structures. They are projecting from the lateral wall. Another thing that we can see here, I think, quite nicely is our hard palate on the anterior portion of the floor of the nasal cavity or roof of the oral cavity. So something else to spot there. So remember, anteriorly we had that bony structure. I'm trying to see what else could we see. We are starting to see our frontal sinuses appearing here above the eye sockets. And notice how eye sockets are, there's a lot of fatty tissue cushioning there. We see some muscles running through as well. These are frontal sinuses, superiorly, we can see them nicely. We can also see our maxillary sinuses, the largest paranasal sinuses, symmetrically on both sides here within the maxillary bone. They are very nicely visible here. I'm thinking maybe we can see a little bit more on this second image. And what I need to do, I need to use a little bit of an eraser here to be able to expose a structure that I want to discuss with you. So thinking back to the end of the BIO201 that you covered, you remember probably olfactory bulb. Direct expansion from the brain, we can see it there, right just below the brain, above the nasal cavity for the sense of smell. Of course, sense of smell and taste, they are very closely associated. What else could we see? I think we can see nicely the submandibular salivary glands. They're just on the both sides of the tongue. That's quite a prominent structure here as well. Another interesting structure that we're seeing the large masseter muscle, the major muscle of mastication. And if we move even forward, we're able to see even more structures. And again, let me just do a little bit of erasing here. I want to highlight few structures, and I don't want our view to be blocked from those structures. This should help us to see them a little bit better. So we start to see the sphenoid sinus just above the nasal septum there, and a little bit of the ethmoid labyrinth is showing up as well as we talk about those paranasal sinuses in a minute. I just want you to be able to see those. I think we're also, I'm trying to observe carefully. I think we might be starting to see the parotid duct getting cut there on the left cheek, lateral to the masseter, and we can see a lot more also on a MRI image. So we have here a coronal and sagittal section of the nasal cavity. MRI is especially well positioned to image the soft tissues. So we're seeing a lot of these structures that we already discussed. I would especially point out here the very prominent Conchi. I think we're seeing all three there that show up quite drastic. Same here on our sagittal section. Well, having done the quick overall survey, I think we're well positioned to move onwards and have a look of the paranasal sinuses. This is an X-ray image. So what we're seeing here, probably a lot of distortion from the amalgam dental fillings, so metal showing up there. You probably need a pretty good screen to be, if you have a little less trained eye, to be able to spot those sinuses, these air-filled spaces within the skull. So let's have a look of those. I have another picture that might be a little bit easier. Let me just erase what we drew there so that we have a little bit clearer of a view. And I'm gonna try to match these with the colors that we used on our review sheet. So that's why I'm looking to this side, trying to make sure that we make it easier. So what I've done, just if you have a little less practice, if your screen is less than ideal, I have actually outlined the sinuses for us here. So let's go through them together and have a look of them. So first of all, we're able to see our maxillary sinus. And I'm just gonna change the color for that. Again, like I said, I'm trying to make sure that we match them as well on all of our nodes with a rather similar color. So our maxillary sinus, of course, within the maxillary bone, within the maxilla. So they are the most prominent ones here, very, very, very visible. And I always encourage you, try to get as many angles of the same structure to really appreciate the three-dimensionality of the structures. So maxillary sinuses within the maxilla, and the next one that we should talk about is going to be our frontal sinuses within the frontal bones. Again, similarly to maxilla, on both sides, symmetrically, this time the frontal sinuses on top of the orbits, really showing up there. We might also highlight our sphenoid sinus. So sphenoid sinus is not really visible on this first picture, but further down here, kind of showing nicely on a lateral view, deeper within the skull, within the sphenoid bone. And finally, I know that some textbooks, some instructors prefer to talk about the ethmoid sinus. I find that ethmoid labyrinth is probably more descriptive of this structure because we don't just have one sinus, one opening there. It's a bundle of interconnected networks. So I think the labyrinth describes the character of this structure quite nicely. And I'm noticing that I forgot to mark the frontal sinus on this image, so I'm just adding it there if you're using the color coding. So one of the things that we discussed about the sinuses was that we were trying to speculate the reasons why sinuses have evolved. Why do we have them within the skull? Some of the reasons that we saw was that bony skull is heavy, and carrying that up with the neck is a lot of work. So if we are able to decrease some of that weight, that might come in handy. That's fairly well accepted explanation. Another explanation that we can prove quite well with just experimenting is that the paranasal sinuses have a major role for the voice resonance. Remember, voice is produced at the vocal folds, at the voice box further down, but further manipulated then at the level of the mouth. The sinuses do play a role in the voice resonance as well. The third explanation that we had a look of is a little bit less well accepted. Similarly to a car's front part is designed to actually collapse in a front-end collision. With that collapsing of that, is the idea is that it absorbs some of that shock force so that the passenger doesn't get that strong of a shock. So it has been speculated that our paranasal sinuses might serve the same purpose if there is a head forward first on collision, to kind of take a little bit of that shock that would be otherwise exposed to the brain away. So I'll let you make up your own mind how you feel about that. The fourth explanation, again, something that we're not quite yet sure, but we have indications. Goes with the immune system that we've been speaking about, that we don't fully understand the immune system yet. Paranasal sinuses might play a role that's greater than we have appreciated in terms of the functions of the immune system. Here we have a really nice CT picture, and what we're seeing here is a case of sinusitis. You might remember from medical terminology, itis is an inflammation of something, and here we're seeing an inflammation of one of the paranasal sinuses. I think that this one especially shows a complete opacification of the right maxillary sinus. This image has been acquired with a CT scan without using a contrast, so it's showing up quite nicely there, whereas earlier on we saw it on the previous picture here. One thing to bear in mind when you're looking at these pictures, there is a tendency to overdiagnose these if you just rely solely on these. The other thing that I wanted to briefly discuss is, why would you use CT, not MRI, when you're looking at for signs of paranasal sinus inflammations? MRI is really not ideal when we're trying to tell apart the bones and mucous membranes. It's rather ideal for soft tissues. So CT, which is much more adapt for the for the bone imaging might be better there. So a couple of nice pictures kind of bringing in the clinical relevance to what we have seen. But let's return back to this mid-sagittal cavitary dissection that we have seen. And we're going to continue our journey further down on the respiratory tract. And a couple of structures that I want to highlight here. First of all, we're seeing our epiglottis here, this flap-like structure. We get to talk about epiglottis a little bit more in just a moment, but really, if you want to keep a rule of thumb or kind of remind you, well, epiglottis is this flap-like structure that depresses during the swallowing. We try to cover the trachea so that food or liquid doesn't make its way there and then to the lungs. So we're seeing the trachea here nicely as well. One thing to notice is the trachea is more anterior. Behind the trachea, we can then see our oesophagus. I believe Americans I believe that Americans prefer to write it without O, unlike British, so whichever spelling you prefer, that will be more posterior. And we'll talk about the importance of their spatial relationship to each other in just a moment. I think that this is a good time for us to jump into this picture where we see a CT picture, and I would typically challenge students to try to diagnose a little bit or try to locate themselves. What do we see here? Well, what we see here is, of course, our larynx, our voice box. We can see many of the major cartilages there. We're going to talk about them not really using this CT picture. We're going to use a diagram that I've drafted, shown there on the right side of the screen, and then apply that a little bit. One thing that I want to point out from the CT, though, that stands out really nicely is our hyoid bone here. We see the hyoid bone also on my diagrams, as you can see. Hyoid bone is kind of an interesting one. It is the highermost part of the larynx, usually kind of a U-shaped structure, commonly broken if someone gets strangled in forensic work, but not the definite always the case. It does provide the attachment point for the muscles that form the floor of the mouth as well. If we look at the diagram, let's go through some of the major cartilages that we can see there. So we can see our thyroid cartilage here on the kind of a green color from the front, and then when we cut the view halfway, we can see it there as well. And thyroid cartilage, we have a couple of spots that I want to highlight, especially. Let me just change the color of the marker here. We can see the laryngeal prominence protruding out, most anterior part. Many of you might know it as an Adam's apple. What else can I say about thyroid cartilage? It is the largest cartilage of the larynx, sits very anteriorly above the thyroid gland. We've talked about that before. Not fully closed from the back as well, as you can see from this cross-sectional view that we have here on the right-hand side. Next, I want to talk about our cricoid cartilage. So that's the lowermost part of the larynx and laryngeal cartilages. It is actually the only laryngeal cartilage that fully encircles the larynx. So only full circle, sometimes described also as a cricoid ring. It functions as the back of the voice box, so attachment site for many muscles, cartilages, ligaments involved in the opening and closing the airway, producing the speech, and so on. Maybe interesting side note, I am not by any means wanting you ever doing this without proper training, but when they do have to put in the breathing tube in surgery, anesthesiologist would push the cricoid cartilage to close off the esophagus further back there to seal off prevent the gastric reflux, the backflow through the esophagus as well. So something to bear in mind. Let's have a look of next. I think we're going to talk about epiglottis. So we see the epiglottis poking out here, and on the side view, this flap-like structure. Epiglottis, the term itself, you can kind of think of it meaning above the glottis. Glottis is the space between the vocal folds. So it really explains where the epiglottis is located. This does include the epiglottic cartilage, but it is covered typically by mucus. Epiglottis is normally open, so we want to ensure the airway being open. So it's typically open at all times for the air to be able to enter in and out to the lungs. So breathing comes as a priority. It does close during the swallowing to prevent the liquids and foods from going down the trachea. I also want to highlight Ethmoid cartilage. Ethmoid cartilage, this kind of a three-sided triangular structure within the thyroid cartilage, hidden there inside. We have two of them, one on the left, one on the right side. It provides the posterior attachment point for the vocal cords, and we can actually see the vocal cords also on this diagram here nicely, and we'll talk about them in just a bit. And there are muscles, arytenoid muscle, for example, that controls the position of the arytenoid, so we can tighten and loosen the vocal folds. We can also see corniculate cartilage, the very tip on top of the arytenoids. These can sometimes be fused with the arytenoid as well. Final one, that I want to show here is our cuneiform cartilage, kind of highlighted on this diagram as a dotted line on a yellow color. It really comes from a Latin word referring to wedge-shaped. So it's this elongated piece of elastic cartilage inside the mucous membrane. So it's hard to see really there. Its function is really to support the vocal cords and provide structural support to the soft wall in general. What we are seeing here on this CT picture, I think I ought to share with you, just so that no one's under false impression. We are seeing a sick patient. So we have some soft tissue here projecting from to the larynx and trachea from the back. So it's a patient that is not totally fine. Let's quickly revise what we saw earlier on by looking at this series of views of our larynx. So here much of the other than cartilages have been cleaned off on this dissection. So we see our thyroid cartilage nicely from the front anterior view. From the lateral view, we see the laryngeal prominence, our Adam's apple, quite nicely pointing out. We can see our epiglottis pointing, peeking out from there. And also when looking from the back posterior side, that big flap-like structure, epiglottis. We can see our hyoid bone. We discussed that at the very start. What else could we see? We can see our cricoid cartilage, the only fused full ring lowermost part of our larynx. What else can we see? We can see our trachea running down nicely. One thing to notice with the trachea here is that we see these tracheal cartilages, these cartilage rings here. When you look closely on the lateral view, you'll notice that they don't continue all the way to the back. So if I'm doing a sketch here where the anterior is here and posterior is here, they're kind of just U-shaped rings looking down on this diagram that is just sketched. They're open from the back. So that's our trachea there. These tracheal cartilages. Their role is really to strengthen the trachea. There's a lot of membranes and ligaments named based on where they connect, such as thyrohyoid and so on. I also wanted to share that the oesophagus, of course, was located more posteriorly to the trachea. So the reason why the tracheal rings are open from the back is that usually oesophagus is kind of constricted closed when not in use, but sometimes you can swallow something really big. It gives us a little space for this oesophagus to extend by having that kind of openness there at the back as well. I'm having a look here. We see actually rather nicely. I'm looking if there's anything else that I could point out. We can see rather nicely on this posterior view that I have here. Let me just erase few structures that we have a nice view. We can see our arytenoids really clearly on both sides. And we can also see our cricoid cartilages on top of them. Epiglottis as well, like we discussed earlier on, is really prominently visible here. The flap-like structure. I think that's all I can think of that I really want to highlight. Up. So I hope that woke up everyone who was asleep. So if nothing else, so what we're seeing here is, of course, singer's vocal cords. This video has been acquired with a laryngoscopy. So camera that goes down the throat to record the vocal cords at a definite skill, not to cause damage and get a good view. The vocal cords, we can see them coming together and vibrating very fast. When singing or speaking. In fact, they are so fast that you cannot see it really well on the camera. That's why it looks like almost like they're moving on slow motion. The higher you sing, the more stretched out your vocal cords become, and lower you sing, the more relaxed they are. Remember though, that even though voice processing starts here, the voice gets further processed at the mouth. But we can see also here are nicely, you see those little trachea rings when we get light showing in there from between the vocal cords, between the glottis, rima glottis, and we can see our epiglottis nicely, the flap here also. So really, really impressive picture. One thing to notice with the vocal cords, they are not red because we don't have any blood supply there. So that's just showing up as pale. I also have attached some X-ray and some CT images here of the larynx, arytenoids, our cricoid cartilage. So few things to notice there as well in terms of the imaging if you're wanting to observe. This next image has been acquired with a technique known as bronchography. That's an X-ray of the bronchial tree after it has been coated. The airways have been coated with a contrast agent. These days, this is rarely performed, as it has been made redundant with the improvements in the CT technology. What we're seeing is the bronchial tree. A couple of structures to know about the bronchial tree. You can see where the trachea divides into primary bronchi, the division point. That was our carina. So important anatomical landmarks to notice there. We can see nicely the primary, secondary, and even tertiary branches of the bronchial tree as well. Eventually we would end up, I don't think they're showing up that nicely, but we would end up with the our intralobular, terminal, and respiratory bronchioles. The other picture that I have here, I don't want you to be shocked, so if you're squeamish, you might want to skip this part. We're seeing a vet surgery of a dog. So a couple of things why I included them. First of all, I want to remind you the trachea was of course ciliated, so those little hair-like structures on the mucous membrane. We do have less cilia as we move down the respiratory tree, so the amount of cilia decreases. The function of the cilia is really to wipe up material up the respiratory tree towards the throat, so we can swallow and get rid of that. Other thing that we're noticing is that the amount of cartilage is higher up on the respiratory tree and then decreases as we go down the bronchial tree. The amount of smooth muscle instead grows as we move down the respiratory tree. So a lot of the cartilage gets replaced with the smooth muscle. But coming back to this picture that I mentioned here about the dog's surgery of the trachea, it is common, especially in small dogs, for the tracheal rings to become progressively weaker and weaker as the composition of the cartilage in these is dysfunctional, and that can lead into collapse of the trachea in certain small dogs. So surgery is one option if the medicines don't work. Prognosis post-surgery is really, really good, but remember, this is comparative anatomy, not something that would be really relevant for us humans. Next, I wanted to talk a little bit about physiology with you just quickly. You should, if you're thinking of what you need to know in an exam, you should be comfortable with what gases are where, to which directions they are going, and at what sides. And I have also provided this diagram that we have on the left side of the screen on your review notes. So we will go through them in the class. I know we didn't have much time during our last session, but we'll wrap it up, the physiology part, during the lab time. But I do want to discuss through the phases of respiration by using this as a guide. So the first phase of respiration is going to be our pulmonary ventilation. And pulmonary ventilation covers the exchange of the air between the atmosphere and the lungs all the way to the level of alveoli. We're seeing one alveoli super scaled up on this diagram here. Then the second phase of the respiration would be here our gas exchange, and it's gonna be external gas exchange. And external gas exchange really refers to the exchange of the oxygen and carbon dioxide between the alveoli and the capillaries of the pulmonary circulation. So we're exchanging, the oxygen gets picked up and carbon dioxide gets put out to the lungs, and oxygen gets picked up by the blood of the pulmonary circulation. That's our second stage, external gas exchange. Third stage is going to be our gas transport, and notice that that's of course in the blood that we're transporting the gases. So circulating the blood supply oxygen to the cells and bringing back carbon dioxide towards the lungs characterizes the gas transport in the blood as the third stage of the respiration. And finally, the fourth stage is gonna be our internal gas exchange taking place here between the capillaries of the systemic circuit and the cells of the body interstitial space. So we're exchanging the oxygen and carbon dioxide between these capillaries of the systemic circuit and the tissues. And this was, of course, because as a result of cellular respiration, we need oxygen. We need to get rid of the carbon dioxide as we are converting nutrients into ATP. So I hope that that made sense. The first half of this slide, the left side, when it comes to the phases of respiration. And next, I want to look at how the gases are exchanged, both at the level of the pulmonary circulation, but also at the level of systemic circulation. So the driving force is the partial pressure difference. And you might remember that we always move materials from areas of high concentration to areas of low concentration due to the diffusion. And if we look at the concentration of oxygen and concentration of carbon dioxide, we can measure that as millimeters of mercury. Doing a little bit of math there. You can see the full math in the lecture videos, but what I want to highlight here is that in the air, the oxygen's relative partial pressure is about 100 millimeters per mercury. However, the oxygen concentration in the blood that's returning to the lungs from the systemic circuit is only about 40 millimeters of mercury. As a result, we're going from areas of high concentration to areas of low concentration. So you'll notice oxygen is moving from the alveoli that are filled with the air from the surrounding us to the blood in the pulmonary capillaries, and we end up evening out this relative partial pressure between the air in the alveoli and the blood that's leaving the pulmonary circulation. So we go from 40 to 100. And that's the direction of the movement from areas of high concentration to areas of low concentration. We can also look at the partial pressures of the carbon dioxide. There's about 40 millimeters of mercury in air around us, in the blood returning from systemic circulation to the lungs, 45 millimeters per mercury. So there is clear difference between high and low relative concentrations. So we're moving from areas of high concentration to areas of low concentration. So from the blood in the pulmonary capillary to the lungs, and that then gets breathed out. So as a result, once the blood has passed the pulmonary circulation, we have brought down the carbon dioxide concentration in the blood to the same level that it would be around us in the air. So that's our pulmonary exchange. Let's have a look of what's going to happen in our systemic exchange. And we're going to start by looking at this blood coming from the lungs through the heart and now entering systemic circulation, having the 100 millimeters of mercury as a partial pressure concentration for the oxygen, so same as the air around us. In tissues, the oxygen concentration is typically around 40. So we're moving from area of high concentration to area of low concentration. So where the oxygen is moving from the systemic capillaries to the cells or the interstitial fluid. Looking again on what happens with the carbon dioxide, well, now we have to the systemic circulation, the partial pressure of carbon dioxide, same as in the air around us, so 40 millimeters of mercury, whereas in the cells, in the interstitial tissues, it's about 45 millimeters of mercury. So we're moving again from areas of high concentration to areas of low concentration. So the carbon dioxide gets picked up from the cells to the blood and exchange due to that, to these directions. So make sure that you notice that what we're looking at here is the pulmonary exchange and systemic exchange that are taking place. So I hope that that clarified that a little bit. Some important physiology there that for us to know. Next, I want to speak just briefly about the control of respiration. And I think that that's something that we do also want to at least note. So at the level of the central nervous system, the control of respiration, the main control center is going to be our medulla. Or medulla oblongata, if you're using the proper full name. And the further modification takes place at the pons then. So if you remember the, so I'm just putting this wrong way around. So pons here and medulla here. So make sure you get them right way around. For some reason was already running somewhere else in my thinking. So you notice that the brainstem is evolutionary, the most primitive part. Breathing has been an important thing to take care of early on, of vital importance. So evolutionary first developed a structure, also cardiac control and so on from the brainstem. Also in individuals' development, the brainstem is one of the first structures of the central nervous system, so important in that sense as well. This control of respiration at these sites is driven by the receptors that detect changes in the blood chemistry, for example, oxygen and carbon dioxide concentration in the plasma, stretch of the lungs or cerebrospinal fluids, hydrogen concentration. So we're monitoring many things there. And the last thing that I really want to discuss in terms of the physiology, let's go through that by using a little bit of a chemistry shorthand. I think that would be useful. Let's have a look of how different systems are related to each other and what is it that body really does. So this next formula, I assume that you have seen it before in your previous studies, maybe on Bio 156, Bio 181. That is the formula for glucose. So the nutrients, the sugar in this case, that gets converted in our body. So we get the nutrients from the food that gets converted into ATP. And you remember ATP was the cellular energy currency that we use, so drives all cellular processes. And as a waste product, we also produce carbon dioxide, and we produce also water. So it's the energy production that we're really interested, production of ATP out of the glucose, but we are left with carbon dioxide and oxygen that we need to get rid of. So really, when we think of the role of the respiratory system, we're interested what to do with this extra water, with this extra carbon dioxide. Well, we can convert it into something. Let's have a look. And of course, this conversion can take place in the other direction as well. And what we can convert it to is going to be our carbonic acid. So most of the carbon dioxide is converted into carbonic acid. Well, carbonic acid can be again further converted, and of course this conversion can take back direction also back, so it's a two-way conversion that can happen, and we can make bicarbonate. So bicarbonate is how we transport carbon dioxide to the lungs, and there, or the carbonic acid, and then most of it is changed to bicarbonate. And it is really the carbon dioxide now that we can breathe out. We can get rid of that due to the respiration at the lungs. We still have to deal with, once we convert carbonic acid into bicarb, we are left with hydrogen ions. So how do we get rid of those hydrogen ions? And this is where our urinary system will step in. So you'll see how all of these systems are connected to each other. This is really all that your body does. We need digestive system to get the nutrients in, that gets converted into ATP. You remember ATP was really needed throughout the body, largely to drive the cellular processes. We're now left with waste products. Waste product of carbon dioxide and water from the cellular respiration. And I'm going to add a link to the end of this video to the cellular respiration video. I just covered it with another class. And this challenge of having carbon dioxide and water, well, that can be solved with our carbonic acid equation. And carbonic acid then converted into bicarbonate, and we could that way breathe out the carbon dioxide that we had left. The extra hydrogen ions we do urinate typically out with the urine. So that brings us to a pretty good space, pretty good place. A couple of words that I just want to discuss about what happens as we age. I feel that we don't always spend enough time talking about age-related changes. So let's have a look at that as it relates to the urinary system. So as it relates to the respiratory system. So the cilia become less active within the trachea. The mucus tends to become thicker. Macrophages in the lung, their role is to clean the lungs. They become less effective. We do lose some elasticity, so it does become these elastic structures a little harder, more rigid. Bronchi walls tend to become thinner, and there is a risk of them collapsing. Reflexes such as swallowing, gagging, coughing, all of these reflexes slow down. That can cause possible issues as medical conditions. You do become more likely to get respiratory infection. Overall, the amount of dead space in the lungs increases, so breathing is less effective. And of course, also exercising is not quite as well tolerated as one ages. That really brings me to the closure of the key points that I wanted to discuss. And if I have a look of the intended learning outcomes, I think that on this review session, we have hit quite a few of them. I know that we didn't get quite as far with the physiology in our original class as I had planned, but we can totally tackle that in the lab. So tomorrow when we meet, we'll be able to address that. That brings me to the closure of this session. If you have any questions at any stage, remember I am here to help, if not in a class, also in remote setting, so you can choose what time, what method is the best. I usually am best reachable through the Canvas. So I recommend that messaging system there. I do get back to the emails as well, but I would really prefer if you can try to use the Canvas, just because I reply to those much quicker. Email tends to get cluttered with a lot of other messages. But this really covers all that I had planned for this session for us today. I really appreciate you joining me. I hope you found it useful to do a little bit of a more challenging revision. And I will see most of you tomorrow again for the lab, where we will be looking at respiratory measurements through the spirometry. On that note, I'm going to wrap it up here now. I'll add a couple of links to interesting videos that relate to things that we have touched upon at the very end. And I thank you and hope you have a very good rest of the night.